Greetings, Earthlings, and welcome to almost a new academic year as we come up on July 1st. Um, so, making this video for specifically the interns this year. I am Kevin Wolverton, and I'm one of the core faculty laborists at York Wellspan Hospital. Perhaps this video will find a wider audience as well. I'm also the assistant program director. And what else? Also do some GYN precepting for the program as well. So today we're going to talk about sutures, suturing, and knot tying. Let's get into it. So in the video part of today, we're going to go through the PowerPoint presentation that I've got, as well as some videos that I made of different knot tying, kind of knot tying 101, and then basics of suturing technique. And then this is stuff that we'll be working on in the hands-on skill sessions as well. Let's get ready to move forward here. There we go. So, what's up with suture? Why do we use it? Well, to approximate wound edges to promote healing by primary intention. There are, of course, times that we leave wounds open, completely open, or with a wound vac, in order to promote healing by secondary intention. But with suturing material, we're using that to reapproximate skin edges, to close off the skin to prevent infection, prevent fluid loss, so by restoring that integumentary or mucosal barrier to the outside world. We also use sutures to remove potential spaces or dead spaces, like we do in closing the subcutaneous layer at laparotomies. This can prevent fluid collection, so decrease the likelihood of seroma or hematoma formation. And then something that is very important to us and our patients is cosmesis. So we're trying to minimize scar tissue. We're bringing the skin edges together in a way that will hopefully result in the least amount of scarring possible. Anytime we talk about medical topics, I think it's always enjoyable personally and professionally to talk a little bit about a historical perspective. So the very first needles made of bone, and this is a needle that has a small eyelet to pass some type of a suture material through. These first date back to 30,000 years ago. The progression was made to some plant-based material and animal-based, the animal-based being some of the earliest made from tendon or spider silk, eventually sheep intestine, catgut or gut, which we'll talk about later, as well as insect usage. You can put the head of an ant over a wound, and with their big jaws, they'll clamp down on the skin edges, pop the body off, leave the head of the ant on. And this was done not only in some developing nations, but was imported actually into some Western European countries as well. The synthetic materials became available in the early 1900s, both absorbable and non-absorbable synthetic materials. We'll talk about that a little bit later. The idea of sterilizing suture material really came about in the kind of mid to late 1800s. Joseph Lister was one of the first to look at boiling and then eventually using alcohol to sterilize suture material. Obviously, iodine is another way to do it, using the autoclave like we do today for heat and pressure. And then there are, and I'm not sure where this is utilized today, perhaps in ortho, using gamma radiation to sterilize things. Obviously, some mass production. Johnson & Johnson is one of the biggest makers here in the United States. Some antibacterial properties that were incorporated, and then non-suture materials such as adhesive tape and liquids, which we won't really talk about, although you will see steri strips being used a lot, butterfly bandages somewhat, and then the Dermabond, the skin glue, is used to some degree. So let's look at the anatomy of a needle. We've really got three areas here. One area is the tip. We've got the body of the needle, everything kind of here from where the either, well, tapering and potentially sharpened end of it is, all the way back to this area here where the suture attaches. That's the body of the needle. And then this swedged on end here where the suture attaches. So a lot of the suture we use is swedged on, which means permanently connected, but there are some that are obviously pop-offs. I presume you've seen those used, and the suture does pop out from the swedged end here. One of the things that I always tell medical students and residents down here at the bottom, do not crush the ends of the needle. If you really clamp down here at the swedged end, you can turn it into a pop-off. It can dislodge the suture when you don't intend to. And if you grab up here at the tip of the needle, especially as you're kind of working it back and forth to bring it out of the tissue, grabbing the tip of the needle can absolutely dull the tip considerably, so it's harder to pass through tissue, maybe doing a little bit more tissue damage as it goes through. But also, if you bend the tip of the needle one too many times, the tip will actually break off. I've seen that happen a handful of times. Two tip types that we typically use. One is designated on the packaging just with this dot. That's a tapered tip. The other being shown here on the bottom are cutting, traditional conventional cutting needles. The point, so to speak, here is on the side kind of facing the inner curvature of the needle. On a reverse cutting here, the point is facing outward from the curvature of the needle, and then the cosmetic cutting, we don't really tend to have any of those. When it comes to needles themselves, most of what we use are true half circle needles. We do occasionally use kind of a GU, GI 5/8 circle. Up here with the quarter and the 3/8, we don't really tend to use as much, so you won't see them a lot. When it comes to talking about different types of materials used for suture, we usually break it down into synthetic versus natural, and then within each of those break it down into a couple of subcategories of absorbable versus non-absorbable. We kind of start here with some of the things that we use most frequently in gynecologic and obstetric surgery. So the synthetic is absorbable sutures that are braided, so that's the polygalactin or Vicryl, which we use a lot. Also absorbable but monofilament instead of braided, PDS. We tend to use, some people use that for fascia. I think a lot of folks do. Some still use Vicryl for fascia. And then monocryl, you'll see that used a lot on the skin, on the subcutaneous layer, and there are some folks that use monocryl on the uterus as well. When it comes to non-absorbable, so permanent suture, there are some braided. Dacron, Merceline, we don't really use much. There's a Merceline tape that some people use for cerclage material. The monofilaments, Proline and Ethelon, can be used, I think, somewhat in orthopedics, but also some surgeons will use them on the fascia for laparotomies. We don't really tend to do that. We tend to use more the PDS and Vicryl, so the absorbable. When it comes to natural materials, the natural absorbable, really gut or cat gut, is the big one. This is connective tissue that comes, and it's mostly collagen, comes from the serosal layer of bovine or from a submucosal layer of ovine intestine. Chromic gut is just that same type of gut material that's treated with a chromic acid salt. So that lengthens the time to absorption. Chromic has a bit of increased tissue reactivity in the healing process. We'll talk more about that in a minute. When it comes to natural and non-absorbable material, silk, you'll occasionally see that used, especially for vascular pedicles, but that silk is going to be there for a long time, forever. Stainless steel, we don't really tend to use that. I think throughout medical school, maybe in residency once or twice, I saw it used, but mainly in med school saw it used for sternal closures. I don't know, maybe in ortho if they use it occasionally. So as far as the suture material itself, how is it broken down? How long does it last? Monocryl is broken down by simple hydrolysis. It lasts on the order of days to weeks, but it loses its strength quickly. So after 1 week, it has 70% of its original strength. By 2 weeks, it's down to 25%. Catgut or chromic is broken down by proteolytic enzymatic digestive activity, and this lasts in the order of weeks, so anywhere from 2 to 3 weeks. Vicryl, again, which we use a lot, broken down by hydrolysis. kind of similar to the monocryl. 2 weeks out, 75% of its strength, but quite a bit better longevity. 3 weeks out, it still has 50%. So we usually think of Vicryl as lasting anywhere from 4 to 6 weeks, and you could find fragments of it after that. PDS, which I use to close the fascia, is broken down by slow hydrolysis. That lasts on the order of months. 2 weeks out, you're looking at 75% strength, so kind of similar, but all the way out to 4 weeks out, still at 60% of its strength. And then silk and nylon, the permanent things, not really broken down, but they're encapsulated by connective tissue over time, so they would be there for years and years. So let's talk about some of the uses of different suture, and specifically tailor this to obstetric and gynecologic surgeries. Catgut in general, again, that high tissue reactivity, quite an inflammatory response as it's being broken down. As we talked about, it does have kind of a shorter duration as far as how long it's providing that tensile strength. It's really, really rare to see chromic used on the uterus, maybe a couple of older school folks. We don't use it on the peritoneum because of the reactivity and the potential for adhesion formation. Some people use it on the sub-Q, but again, I think it's kind of falling out of favor. Vicryl has a lower reactivity. It does have a little bit more pull on the tissue because of its braided nature compared to the monofilaments. We tend to use Vicryl a lot on the uterus. Some folks use it on the fascia, either running or interrupted, and then we use it especially with pop-off sutures for abdominal hysterectomy pedicle formation. With the two monofilaments over here, monocryl and PDS, low reactivity, high tensile strength. They do tend to slide easily through the tissue. Monocryl having a relatively quick absorption, and PDS really having that longevity. Monocryl, some folks, like I said, they use that on the uterus. You could use it on the peritoneum, although most folks are not closing peritoneum. I actually use it on the subcutaneous tissue, and then use it on the skin for subcuticular closures. PDS, I think most folks are predominantly using that on the fascia. All right, so let's look here at some very fundamentals of knot tying. We're going to watch a little video. All right, let's talk about some basic knot tying. We're going to go through a two-handed knot first, and then a one-handed. Now, there are lots of different ways to do this. What we're going to do is to start off with as if we have a needle on this side. So we've driven it through the tissue. We have our needle driver here. And what I prefer, and this is just strictly speaking personal preference, is to keep the needle driver in my left hand, or to set it down to the left of wherever I'm suturing. And then what I do, knot tying in general is just about creating loops and pulling a free end through a loop. So that's what you do, whether it's a two-handed or a one-handed knot. What I do is I start off over the thumb. So again, we create the loop there kind of around my thumb, swing through at the finger, pinch between finger and thumb, swing it through this way, grab it here. So the free end here, the tail of the suture, is always in control. We're always holding on to it one way or another. And then what I do with that first wrap around my thumb, and when I swing it through, I don't cross my hands over, but I do kind of pull opposite like that. And then my next throw is around finger. So loop there, pinch, swing through, grab that free end, swing it through, grab it, and lay that down. And that gives us, if I get that oriented, our nice square knot. So what we're looking for with the square knot is that we've got the two strands here. You can see the two blue strands that are going through that loop of orange, and the two orange strands on this side going through that loop of blue. So let's just undo this and we'll look at that again. So again, I start off with around my thumb, pinch, bring it through, do that little bit of a crossover. You can see that lays down nicely there. Over my finger, pinch, swing it through, and then lay that down. So again, we've got orange loop with the two blue strands going through it, and then over here the blue loop with the two orange strands closer to the camera. And then it's just repeating that. The first 2 throws that you do complete 1 square knot. So then it's just back to it, over the thumb, lay that down, over the finger, lay that down. So now we have 2 square knots. So if this were a monocryl, I do 4 throws, 2 complete square knots for monocryl. If it's a vicryl, same thing, 4 throws for that. You can do more here, over thumb, over finger, and just continue to lay down. You can see that those are nice, symmetric. We've got, again, kind of the loops and the 2 strands going through. So practicing with a two-tone, 2-colored, this is just a piece of nylon, small piece of nylon rope, like a heavy shoestring that I got and dyed the 2 colors. Perhaps one of the simplest ways to practice this, and this is how a lot of folks do start off, is, let's say that there's no needle, so we just have a free tie here, and you cross the strands over. So you've already created your loop to start with. So instead of, again, having, pretending that we've got a needle here, and then having, some people will hold the needle driver in their right hand and grab the free tie here, so they've got a loop, and then they'll tie with their left hand. That's perfectly acceptable. I hold it here in my left hand and tie, so to speak, with my right. That's fine as well. It's really just whatever you can do that will lay down square knots that are consistent. Again, you'll see a lot of personal approaches and personal opinions on how to do this, but what matters is the integrity of your knot. So as long as you're laying down true square knots and being able to keep enough tension on the suture that they don't turn into an air knot, you're fine. But again, beginning to practice, and I know a lot of you have tied knots of different varieties, and maybe you've really grown pretty comfortable with the 2-handed and even 1-handed knots. That's fine, just continue to practice that. But here we'll say we've got two free ends, a free tie, so to speak, no needle on it, so we can cross it over, no instruments here, and then start with finger. So again, we're looping over the finger. We've already got our loop kind of created for us there. Loop it over the finger, pinch, swing through, grab the blue, bring it through, and there's our first. And since we did that first one over finger, now we're gonna come over thumb, pinch, swing it through. And I still find that I have to kind of, pull oppositely like that. And again, there's our nice true square knot. So we've got the 2 blue strands coming through that orange loop, and the blue loop on the other side with the 2 orange strands going through it. So again, if you have a free tie, you'll always hear people say, cross the strands. So cross the strands, you've already got your loop kind of already started. Over the finger, pinch, swing through, bring the blue, go down. We did finger first, so then thumb, pinch through, and again, I do that little bit of kind of a pulling on opposite sides, and there's our square knot. So that's a 2-handed knot. Let's talk about a 1-handed knot. And technically speaking, as long as you're throwing nice, consistent square knots, 1-handed or 2-handed knots should be equally secure. I do think there's a bit of a stereotype, and I must admit that I have this preconceived notion a bit myself, that 2-handed knots are a bit more secure. So I typically do 2-handed knots whenever possible, and especially for vascular pedicles where I'm really counting on a good tight ligature around it. But 1-handed knots sometimes just for access. If you're tying, say, during a TAH down around the uterine artery, I do 2-handed, but when I get to the vaginal cuff, or if you're really deep, sometimes 1-handed is what you need to do. Anyway, so let's say again, we've got our needle here, so we've driven the needle through the tissue, I hang on to it here, and then the 1-handed throw, I start off over the fingers. So again, we're just kind of creating the same loop in the suture, and then pulling it through. Here, I kind of cross over this way, so you can see that's laying it down nicely. And then when we come, it's over just our index finger. So again, we're creating a loop, putting our finger through, trapping the suture, pulling it through like that. And there's our nice square knot, 2 throws, 1 complete square knot. So again, over the 3 fingers, create the loop, use your middle finger to pull it through, do that. Then over index finger, flip it through and do that. And again, you can see that we're laying down nice, consistent square knots there. So nice simple overview for one-handed, two-handed throws. And again, you can also practice this as if it was a free tie. Just have to quickly undo. So if you have a free tie, no needle, you can go ahead and cross the strands, and then you can do kind of a similar sort of loop, and there you go. So that's a little bit of an overview of simple one-handed, two-handed knot tying. All right, so let's talk about suturing itself. And I appreciate that most of you have not only seen these suturing techniques, but have probably done them yourself, certainly practiced them before, I presume. But I just don't want to make any assumptions about what people do or don't know or have done themselves. So we'll start with some basics, and you'll have plenty of opportunity to build upon it in the next several weeks. So starting off with a simple interrupted suture, and what we're looking at, of course, is one kind of pass driving the needle down through the tissue on one side of an incision or laceration, and then another bite coming up this way. So as is represented here, you're just creating a single loop of suture that then you're tying a nice little knot over here. When you're doing this, you can, if the two sides are relatively well approximated, and if your needle is big enough, you can come down and then right into the tissue and out with a single bite, or sometimes it's advantageous to, with getting a big bite, maybe you've used most of your needle length here, so you would want to come out in the middle, reload your needle, and then take your second bite here, and then tie that off. So simple interrupted suture. Now, we're going to talk about burying the knot, which we do relatively infrequently, but there are a couple of scenarios where it's helpful. So if you come back to this and look at our typical interrupted suture, what we've done is we've started here on, so to speak, the outside. So you're going out to in, and then in to out, and then the knot gets tied up on top of the skin, whatever the layer is. So to compare that to a buried knot, what we're going to do is we're going to start down here. You start off with in and come up to out. So in to out with this first bite, and then the next bite, which they're showing here, is out to in, and then you've got your two free ends, so to speak, down here buried in the tissue, and so now that's where you tie your knot. So in to out, and then out to in to bring that down. And then you've got your free end here, you've got your end with the needle here, and you tie that together. So that when you see it from above, it looks like this. It's just a line of suture. It's not a suture with a visible knot on top. All right, let's look at simple interrupted suturing. All right, so what we have here is a chicken breast with the skin on, and we're going to go through a couple of different suturing techniques. What we have here to start with is a 2-0 vicryl rapide. You can see here this is on a CT1 needle. When we open this up, we'll take a look kind of at the anatomy of a needle. That'll be covered in the PowerPoint slides. You can see here that we've got a 90 centimeter length, a CT1 type of needle. It's a tapered point. It's a half circle needle. The vicryl rapide, it's undyed, so it probably won't have that characteristic purple color that most vicryl or polygalactin has. So there we go. All right, let's take a look at the needle to start with. So the two parts of the needle that we don't really ever want to be grabbing with the needle driver are at the tip, because it will considerably dull the tip, especially if you have a cutting tip. And then we also don't really want to grab at the swedged end here where the suture is attached to the needle, because if you crush that area, it can loosen the suture and it can turn your suture into a pop-off accidentally. We've got here kind of the full curve of the needle, and what we typically do is to grasp anywhere from about halfway back to a little bit closer to the swedged end, depending on how much needle length we need to drive through the tissue. Obviously, the further back you are on the needle, closer to the swedged end, the more you really have to crank your hand over to be able to get a good kind of angle of attack on the tissue. So if you're working with an area where you don't need, if you've got thinner tissue, so you don't need quite as much penetration with the needle, then you can kind of choke up on it here, and you don't have to crank so far over to be able to get that needle to go perpendicular into the tissue. One of the other things that we talk about a lot of the time is angling the needle at kind of a 45 degrees like that. That allows you to get access to the tissue while keeping the needle driver kind of up away from the tissue, so to speak, and we'll see some examples of that. So what we're going to do is just a simple interrupted suture here. We've got our cut chicken breast here with the skin on, so we're just going to stabilize tissue here, and again we want to kind of poke through. We don't want to skim into the tissue here. If we're going a little bit deeper, we want to poke down at a right angle, come out. You can see here in the middle of the tissue here, grab with our forceps, and oftentimes if the tissue is soft enough, we can just kind of curve that needle out with the forceps and then just reload it here at the skin. What we'd like to do is avoid really having to grab the needle with our fingers and then increase our risk of poking ourselves. So first bite through there, we've got the needle reloaded about 3/4 of the way back from the tip towards the swedged end, and I've got just a little bit of an angle there, kind of open it up a little bit. So you're going to grab that tissue, kind of open it up, go in, curvature of the wrist to pop out, grab the needle, pull it through to forceps, reload the tissue. Now, if I'm going to be tying this, I want to protect the needle if I'm going to be setting it down, or even just really holding on to it. So we'll pull our suture through. I'm going to set the needle driver down, and then we're just going to do a very simple two-handed knot. So again, I go over thumb first, create our loop there, swing through with the finger, bring that shortened through, and then again, I don't really cross hands, but I do kind of go opposite directions, or you can just kind of pull straight up and down like that. You can see how that draws the tissue together, but it does relax a little bit, so we want to keep a little bit of tension up as we come up over the finger for that second part, and then as we come down, that tightens up nicely. So this is Vicryl. We want to do 4 throws, 2 complete square knots. So back over thumb, and then over finger, and there we go. So that's our interrupted. We want to cut that usually about 1 centimeter, give or take. One of the things that we oftentimes talk about is burying the knot. So if we don't want to have the knot kind of sticking out above the skin, we can bury it. The way we do that is, instead of starting on the outside of the tissue and then popping out down here on the inside, so kind of going out to in and then in to out for our second bite, what we would do is we would start on this opposite side and start here and go in to out, so to speak. Pull that through, and then we're going to come over to this other side and go out to in. So now our 2 loose strands, so to speak, are down in the interior of the tissue. I want to make sure that we're not locking that, which I was a little bit. So as we pull this through, we want to shorten it up so we have a relatively short side to tie there. So I'm getting caught up on my T-pin. All right, so now as we tie this, what I like to do is get both of these on my side of the loop, so to speak. So we are going to bring this back through. All right, so now you can see that we've got our loop is on the outside, so to speak, and our free end and the part that the needle is on here are exiting down deeper in the tissue. So once we get that set up, then we're just going to do, again, over the thumb first, and then tighten that down, over finger, over thumb, over finger, so 4 throws to complete score knots. And then you can see that our knot is down here in the tissue itself. So on the outside, we just have suture. Up here at this first one, we've got a visible knot, but here the knot's buried down the tissue. So just going from, and we'll just do another one of those quickly. So starting, instead of here on this right-hand side on the outside, start on the other side, we go inside to out. And then outside to in. Pull that through. And again, I like to get this free end on this same side just so we don't end up kind of locking that. Finger, 4 throws for vicryl to complete score knots. Yeah, so we've got that buried knot. I think I might have locked that a bit. All right, so that's just simple interrupted. And again, we want to get the needle attacking the tissue perpendicularly. We don't want it to really slide into it unless we're taking a very, very superficial bite, but we really want the needle to be at a right angle to the tissue, and then as soon as you poke in, start to rotate your wrist. That way you don't go too deep. Come out, at least visualize the needle in the middle of the tissue. You can go across in one pass in some instances. If you get to this point and you just have a little bit of the needle tip that's visible, you can just re-grasp over here, drive a little bit more of it through, stabilize with your forcep, and then you can rotate it out with the driver or with just the forcep itself. Grab, we're going to protect this. And again, thumb first for me. Always a good idea to practice knot tying with a pair of surgical gloves, because that's how you're going to be doing it in the operating room, and so you want to get that feel for handling instruments, handling suture, tying suture with surgical gloves on. So there you go. Simple interrupted with exposed knot and buried knot. All right, so after having talked about interrupted suture, let's talk about running or continuous suture. So the first approach to the tissue is the same as for interrupted. If you're not burying the knot, you'd start here on the outside and come down to inside, and then inside to outside here, and then you would go ahead and tie your knot. But then when you're cutting the suture, you've got your free end and your end that comes over to the needle. We're only going to cut the free end, leaving the needle attached. And then with that, we're just going to make a series of very similar passes through the tissue as if we were doing just interrupted bite after interrupted bite. But instead of tying them together, we just keep going. That's the running aspect to it, obviously. And then as you end up finishing up, you get this sort of appearance. You get this sort of angled appearance to the suture by taking your bites through the tissue straight across. You can take bites through the tissue at an angle to make it so that your suture lines up nicely like that. I don't think there's any difference in tissue healing. In the end, I don't think there's an issue in the cosmetic appearance of it. The only difference is how the suture lines up while things are healing. We don't really tend to do this sort of suture exteriorly anyway, I've only seen it done once, actually in college by an ENT plastics, who would do long lacerations on the face with a very fine, like a 5/0 kind of running continuous thing. And he did it so that it lined up, parallel. The suture itself was parallel, beautiful. Anyway, so then once you take your final bite, so let's say that, here is the end of the division of the tissue. So we've gotten down to that. We're going to tie, but instead of having a single strand like up here with our interrupteds, or the beginning, this first knot, where we have a single strand of suture to another single strand, here we're going to have this loop of suture and then a single strand. So let's look at that. All right, let's talk about running sutures, and you've got that same to a vicryl. So instead of the interrupted, where we've got this space in between that's not being directly compressed by the suture, a running is good for a little bit more efficient way to close long openings, to get relatively even tensioning across, and to some degree a bit more hemostasis because the tissue is being a bit more compressed. But in a minute, we're going to take a look at a running interlocking suture that gets even better hemostasis. So in general, we usually start up beyond the apex of the incised or lacerated tissue, because any divided tissue could be a source of bleeding. So we want to come up just beyond the apex. See our needle tip here in the middle. We'll come out in the middle, regrasp, go back in, and again pop out just up behind that apex. So what we've done here is we come to tie this, and we're going to do an instrument tie just because we are running a little bit short on this suture. But what we've done is we've made it so that as we tie this and get tissue compression, we have the beginning of tissue compression up beyond where the tissue is actually divided. So every bit of divided tissue, possible areas of bleeding, cut or exposed blood vessels, will be kind of within the line of our suture. So let's talk about instrument tie real quick. Wrap it around, it's the same thing, it's just getting a loop of tissue and then pulling a free end through it. So wrap your loop around the tip of the needle driver and pull through, wrap the loop around and pull through, wrap, and through. So 4 throws there for vicryl. All right, so instead of cutting both sutures, which we would do if we were doing just an interrupted, we just cut the short suture, the part with the needle attached, we've obviously left attached. And so now we're just going to come down and do side to side. And again, here we're doing in kind of one pass, reloading the needle at the tissue, pulling that through. Here we'll kind of come out in the middle, say we've got a bigger gap here or real deep. Now we're also trying to get all the way down. You can see how far deeply the tissue is divided down here. Again, any divided tissue, whether we've incised it or it's torn open because of laceration, you can see where my needle's coming out. So everything from my needle up is going to be contained within the compression area of the suture. But all of this tissue down here is not going to be contained. So there could be ongoing bleeding there. And it might not be as well reapproximated. So you could look at ongoing bleeding, potentially hematoma formation, potentially a bit of a gap there, a little gaposis where it's not going to heal as nicely. This is a little bit of a smaller needle than I would typically use for a deeper wound like this, but let's back this out, take a little bit of a bigger bite there. Now I've gotten down really to the bottom of that defect. And then with this next bite again, I want to get all the way down to the bottom of where that defect is started, and then curve my way up there. And pull that through. And then we just keep doing that. So in here, come out in the middle so I see my needle tip, can control exactly what depth of tissue that I'm going down through, curve that out, reload at the tissue, and pull that through. Now, you can see here that the skin edge on the left is really tucked up right against the edge of our incision. The skin edge on the right here is kind of falling off to the side, so we have what looks like a little bit of a gap. So if I wanted to correct that, I could really grab skin edge itself and to make sure that I'm really incorporating that into my bite. So now, as I come across here, hopefully that will get that right skin edge a little bit closer. The other thing that I can do is to actually grab and pull that over so that as I tighten the suture, so you can see the difference between having a little bit of a gap in skin edge here and then how closely that bite brought it over. So again, I'm going to kind of grab skin edge and I can evert it to see right where my needle tip is coming out. Come across here in one bite, drive a little bit more of that needle length through, and then again, as I'm tensioning down the suture, I can kind of grab tissue and place it where I want it and get the closure that I want. So again, we've got a little bit better closure on the skin with those last couple of throws. And we'll do one more here. All right, so now that we're getting towards the end of our incision, what I typically do, because again, we want to have both our first and our final pass of the needle and suture beyond the apex of the cut area. So I don't really feel like I have enough room here to do one more bite through the tissue and then one beyond. So I'm just going to do one more right beyond, just a little through and through like that. And then when I go to tie this, all of that tissue will be contained kind of within our suture, so to speak. And since we're short here, again, I'll do a little instrument tie. I'm going to do a little wrap, grab that loop with my very cheap needle driver and pull it through. And again, loop around the tip of the needle driver, grab my free end, pull it through. There you go. That's just 2 throws, which normally we do 4 for Vicryl. And then we'll cut that. So, running continuous suture, talked about the different depths that we get to. We want to make sure that we start and end beyond the apex of the defect, that we want to go full depth of the defect to get all of that divided tissue, areas of disrupted blood vessels, and so sources of potential bleeding contained within the suture so that it's going to be compressed.
All right, so that was using the 2O Vicryl undyed. So as a comparison for suture, I've got a video here of using a PDS, which is what I typically use on the fascia. A lot of folks do. And this is also just a running continuous suture. So let's take a look at this.
One final video here. This is a PDS that I use to close fascia. This is a 1 PDS. It comes on both the CTB1, which is kind of like a CT1 equivalent, and then the CTX. You can see that both of these are tapered needles. Both the CT1 here is a half, and I believe the CTX is half as well. They're both 90 centimeter long as far as suture length, and they're the PDS2 material. So we're going to use the CT1 equivalent here just because it's going to be a little bit easier, but I just want to show you the size and kind of heftiness of this stuff. And again, this is what I use to close fascia. So a nice heavy suture. It's a monofilament. It does have, you can see that it tends to kind of really bunch up, and it has all of its little curls in it. So it has a long memory. One of the things you can do is to just kind of run it through your hand, pull it, give it a little bit of tension, and that will tend to straighten it out a bit. But one of the things with PDS is that it requires 4 complete square knots, because of how thick it is, being a monofilament, having that memory, it needs very secure knots and a lot of them. So it's 8 throws, 4 complete score knots. So we're just going to do a couple of kind of interrupteds here. We'll come down, see if we can go across in one here. This does leave quite sizable knots just because it's a thicker suture. Some folks do use a 0 PDS. I like the 1 for fascia. And again, over the thumb and down, you can see how really clearly visible the suture is. Over the finger, and down, thumb, down, finger, down. So that's 4 throws. That's 2 score knots. We still need to do 2 more. So thumb and finger, that's 3 score knots. Thumb and finger, that's 4 score knots. So 8 throws, 4 score knots. So you can see that that leaves a lot of suture material in the knot itself. So when you're using this on fascia, if it's in a thin patient, these knots could actually be palpable through the skin. So one of the things you can do is that you can try to bury them. So we can come down, and again, we talked about burying an interrupted, or just burying a knot is starting down here in to out. And then out to in. Pull this through. So finger first here, just because of how it's lining up, and then tighten that down. We did fingers, so there's thumbs. This is our first square knot. Throw number 3, number 4, 5, 6, 7, and 8. But now, instead of having that huge knot sticking above the skin, it is buried down in the tissue. So that's one thing that you can do with PDS, is to bury that knot so that it's not sticking up quite so much. The other thing that you can do, and here we're just going to do kind of our traditional interrupted. So again, thumb first, finger, finger. All right, so actually let's do this as a little bit of a running. Back off our zoom there a little bit. So if I was using this to close fascia, I would do this as a running. So here, and you can see that when we go to pull through this first pass, that it does kind of pull the knot and it kind of tucks it under the tissue a little bit. So we'll do another pass there, and another. So nice running. All right, so let's say we're going to tie this next one. We're down at the end of our defect. So this is a little bit of a challenge because we've got 3 strands, 2 strands in our loop, and then the single strand. So it just makes for an even bigger knot. But again, we treat our loop as kind of a single strand over the thumb, cinch that down nicely, and then finger, thumb, finger, thumb. All right, so there's our 4 complete, and you can see this knot's going to be sticking up above the tissue. So one thing that you can do is to cut the loop, and I'm cutting this fairly close to the knot, and now we've got this. So we're going to bury it. And the way that you can do this is you can come, I kind of backhand this, and I just travel kind of along the suture line, not going too deeply, but just kind of traveling along the suture line. And And just doing one bite like this, you can usually get it so that it will kind of pull the knot under a little bit. Occasionally, I'll even do two like this and kind of come over to the other side, do a little bit of a backhand. I typically don't do this. It's just something that you can do to try to bury this knot so it's not quite so prominent, and then you just cut this kind of flush with the tissue. So compared to this interrupted where the knot's really sticking up above, where we buried the knot completely invisible, here with our running, this first one got tucked down, so at least kind of on the tissue, and then this one here really sticking up, but with trying to bury it, pull it under, it's a little bit better. So that's PDS.
All right, so we talked about running continuous sutures. We tend to use those on tissue that needs to be reapproximated, but that's relatively hemostatic. So we tend to use it if somebody's closing the peritoneum, which you won't see much, but closing the fascia, closing the subcutaneous space, people tend to use a running suture for that. So you get good tissue reapproximation. However, if you have an area that's bleeding, that's a bit more vascular, and you want to get better kind of overall tissue compression along a long kind of linear defect in the tissue, whether it's a laceration or from our doing an incision, doing a running but interlocking suture will do a better job of putting pressure all down the length of the incision. So we use this typically in closing the hysterotomy, so closing the uterus at the time of a C-section. And let's look at this. So again, just like our running, we start off with something that looks very much like an interrupted, out to in, and then in to out, and we tie that knot, and then the free end here, we lop that off, leaving the needle attached. The difference here is that when you take the needle out during this second pass, you run the needle through this loop that's existing from your previous bite. So if this was our original bite and then this is our, say, second bite, with the second bite you run it through this loop that's been created, and then each subsequent bite, and each bite is going through the tissue just like doing a running suture, but you're pulling it through this little loop. And so this is what that looks like. Most of the time you do have an assistant that's holding up, and obviously even for just a running non-locking suture, usually you will have an assistant holding that for you. But your assistants holding this, they can actually help to kind of open this loop up or place it over the needle. So then when you pull this through, you get this. So we've got our line here from our first pass, and then kind of this second pass through the tissue, but then the needle has been passed through the loop, so you get this visible part of tissue here. So what you get is more of a kind of parallel track of suture with this little connecting piece in between each, so that you're getting compression not only kind of side to side, so perpendicular to the axis of the incision, but this is also creating tension and pressure longitudinal to the incision, so that if you've got areas in between the suture that could be bleeding, as for example the hysterotomy at the time of C-section, this is going to be putting pressure on those spots. So let's take a look at that.
All right, so we're going to be looking at a running locking suture. We've got a different suture here. Instead of that 2O that I had, now I've got a 2O chromic. So again, 2O chromic gut. This is on a CT1 needle. Again, it's a half needle, the tapered point. We've got a 70 centimeter length to it. As opposed to Vicryls coming dry, chromic and gut usually come in alcohol to keep them moist, because when they dry out, they get quite brittle. All right, so running interlocking. Again, we're going to start up beyond or right at the apex of our defect because we want to get all of that divided, separated tissue compressed within our suture line. So we're going to come up beyond, come out in the middle, reload here at the tissue, go down to full depth, pop out just beyond apex there. So when chromic is wet, it does pull through the tissue fairly easily. Going to protect our needle there. Needle is down protected, and again, two-handed knot here. Oh no, what the heck, let's do it one-handed. So for me, one-handed, again, I have the needle attached over here to my left. So I start off with the free end here, and I wrap around two fingers, so I'm making my loop there, and then trapping the free end and pulling it through, and then I do that little kind of crossover, and then make the little loop around index finger, do that little kind of pull through, so I trap it, pull it through that side, and then down. And so again, over those middle two, index, middle two, index. Oh, that one slipped out. Like that. So laying down again. Some people do over all three fingers here. I tend to just over the two, make that loop, snag it, pull it through. So this free end is always under control. It's always kind of within your grasp, so to speak. And then with just the index finger here, loop over there, pull it through, kind of rotate. Once you get that trapped, rotate your hand this way to get that up, and then come up, pinch it. Now I've got it, and go down, and then that sets you up being ready for the next over those fingers again. All right. So running interlocking. We do this most commonly on the uterus because we need good hemostasis along the hysterotomy. Oftentimes, most of the time, we'll have our assistant who's holding the end here following us. So down through the tissue, come out in the middle. We're going to do this across in one bite. I can't quite see my needle tip, so I'm letting go of the needle and kind of backing up on it, and then continuing to drive it through until I see the tip, grab it with the forceps. If it'll just slide right out as I kind of curve my hand over, that's fine, and then I can reload here down at the tissue. But what my assistant's going to do, instead of just pulling it through like this, that's what we did with our running continuous there, we're going to take the needle and pass it through the loop. So what that does now as we tighten it is, you can see here that we're pulling through this loop, and we get some extra tension created along that area we're closing. So let's look at that again with our next one. So we go down through, and then up and through. Use the needle driver, kind of finish curving that needle out of the tissue, re-grasp here, and again, we're going to want to, and our assistant would be helping us with this, here's our loop. And so we want the needle to come through the loop. So as we do that, you can see that we have suture here. So we're not only doing the loop through the tissue, but we're creating this little extra strand that comes down. So we're getting more compression of the tissue. And we'll just continue to do that. We can see there's a little bit of skin pulling away from the edge, so I can really specifically grab that skin edge and pull it over to make sure that I get it in my closure. And then one of the things we can do is I can just bring my needle driver through this loop right off the bat. And then as I reload the tissue, I'm pulling it right through the loop in the first place. So again, see that good compression there. So again, we just go down, see the tip of our needle, come across in one, curve it out with the forceps, reload at the tissue. But instead of just doing that, I want to come through the loop itself to reload. So then as I tighten this down, like that. So again, you can see that we're really getting nice compression here. And compared to this running, where the tissue in between our loops of suture isn't really overly tightened, it's really just tightened where the loop is passing. But here we're getting compression not only side to side with our loop, but also some of this kind of longitudinal or compression that's parallel to the direction of our incision because of the interlocking aspect of it. And let's see, we'll again grab that skin edge and try to get skin, pull it over a little bit better, come out in the middle, come through our loop to reload. Here. So a lot of people have questions about how you kind of finish up doing, so I'm just going through the loop, grabbing needle, pulling the needle out there. All right, so we're almost to the end of this incision. We've got just a little bit left here. So when we go to tie this, so I'm going to do one more bite that's right beyond the apex itself. And now, instead of reaching through the loop to grab the needle, because that would in effect just be locking it again, I'm just going to pull the needle through. We're going to protect it, pull the needle through. So now we have a loop on this right side and the single strand here. But we tie it just as we would, kind of as if this was a single strand over here. Two-handed knot. So wrap it over thumb, bring this over again, kind of as if it were a single strand, bring it through, and then tie it down. One thing that a lot of folks do is that they'll kind of work this loop back and forth a little bit to make sure that it's snug, that it's kind of evenly pulled through. So over the finger, keeping some tension there. And then I got a little bit of an air knot there over thumb and through finger, through. You can do a couple extra here, thumb, finger, like that. And now we've got three pieces of suture, two here in the loop and then the single strand to cut through, like that. And again, you can see that we've got not only this kind of lateral compression because of our looping through the tissue, but because of our locking area here, which you can see this little piece that kind of goes from loop to loop to loop all the way down, we get that longitudinal compression.
All right, so the next thing we're going to talk about, and this is really just more of a closure of a certain layer, the subcutaneous tissue. And this is something that we'll talk a lot more about in the operating room, but for the most part, the recommendation is if the subcu space is greater than 3 centimeters deep, that you should close that off. If it's less than kind of 2 to 3 centimeters deep, then you don't really need to. I still typically do close it, even if it's quite thin, just to get the, so if we're going to call this here the subcutaneous layer, and we'll say that this is skin here, I usually do close the subcutaneous layer. Just, I think that it brings the skin edges together a little bit more nicely for doing a subcuticular closure of the skin, takes some tension off the skin edges. It also does, by closing off that potential space in the subcutaneous layer, reduce the risk of seroma and hematoma formation, which granted is a larger risk the deeper that space is. But what this is essentially is just a running suture. You can do this interrupted. I would say probably of the folks that I work with, maybe 80% do it running, 20% interrupted. And it's just taking, again, if we're going to call this skin here, and this is the subcutaneous layer here, just doing a initial bite through there, tying it, and then just kind of doing a running over and over as you come down, closing that space. So that in the end, and this is not really representing it, what I would say is the subcu closure would be here, and maybe even a little bit further off from the skin, maybe more like here, because then you come right through this area with your subcuticular. So, but before we get to that kind of two-layer closure of subcu and skin, let's look a little bit at mattress sutures. So, we don't typically do interrupted mattress sutures much, of which there are two varieties, horizontal and vertical. But we occasionally use just that approach to the tissue in more of a running
suture, especially the horizontal, but let's see what we're talking about here. So in general, what we've been talking about so far is going into the tissue on one side of the incision and popping out over here and then tying a knot. So whether we're doing that interrupted or as the beginning of a running layer, but what we're doing is we're kind of continually wrapping the suture around and through the defect. If what we're going to do, however, is a horizontal mattress, what we do is we take an initial bite through the tissue like that, come down, travel maybe a centimeter or so, take another bite back through the tissue like that. So the visible part of the suture that we have here, so it really is a single loop, but it's using tension across this exposed skin to create a larger area of compression. So it's distributing that tension across a larger area of skin. And when this kind of visible area of the suture is parallel to the line of the incision or laceration, then that's horizontal. What we're going to see in our next slide is when the suturing that we're doing is kind of perpendicular to the line of the incision, that's vertical mattress. So let's look at that. So here, what they're doing with the initial bite is, there's a handful of ways you can do this, but what they're representing here is that they're coming in and traveling here for this bite, come out and then in here and across for the deeper bite, and then tying your knot here. So you're doing kind of a superficial bite and then a deep. You could do it, kind of look at it the other way. You do your first bite deep, and then when you pop out and then come back and do this one superficial, that's what most folks would do, obviously. The way they have it oriented here is just a little bit off. So again, here, coming in for this deep bite, popping up, and then in here for the more shallow bite, and then tie across there. So the exposed area of suture being perpendicular to the line of the opening, this is a vertical mattress. And again, it's distributing the pressure of the closure across a larger area of skin and tissue. So you're getting compression really all through this tissue on both sides. What I have in the video is a little bit different than this, but you'll see there. And again, we'll have a chance to practice this when we're in the simulation center. All right, let's talk a little bit about horizontal and vertical mattress sutures. We're going to do these as interrupted sutures. To start with the horizontal first, what this is taking, instead of taking a single bite that goes kind of through the tissue so that it's encompassing this divided area here, it's actually a bite that goes parallel to the incision or parallel to the defect, like that. It's a pretty big bite. This is our CTX needle, so it's quite large. So there. So we haven't actually gone into the defect itself. We'll pull that through. Chromic's getting a little dry, so it's a little bit harder to pull through the tissue here. All right, and then we go over to the other side of our defect, and we don't repeat this bite. If we did that, if we came from here and popped through like such, we would actually be creating a figure of 8, which we had just done in the previous video. So you can see here, and then if we tie that, we've got our figure of 8, our X pattern there. So that's not how we do that. I do see a lot of people in their beginning suturing experiences who kind of mix that up. So again, first bite here, parallel, and we're not actually kind of passing through the defect itself. And then we'll tie this, and again, I'm caught up on. What we're doing is we're pressure here, again, defect with our needle. Our needle passed through tissue on this side, and then the needle passed through tissue here, but we're bringing the two edges of the defect together. But because this is a bit more spread out, we've got to bite through healthy tissue, so to speak, and you can even go further back from the edge of tissue here than I did to create really quite large mattress sutures. But when the needle is passing parallel to the defect, that's the horizontal mattress. So let's contrast that to a vertical mattress where our bite is perpendicular to the defect. But again, we don't come in here and then come out in the defect. That would just be an interrupted. But what you do is you actually come in and out here. What's the better way to demonstrate that perhaps is we can come, sorry, we are going to come kind of through the bottom part of tissue here and out. And then we're going to again kind of backhand this and we pass back. So now we go closer to the edge of tissue here and come out a little bit closer there. So again, we've got that more distributed tension with the suture. So you can see that we're quite a way further from the skin edge than we are with, say, our interrupted. So what we've done here is, again, we've gotten a much broader compression of the defect, but the orientation of the suture that we've been driving was perpendicular. Here, with the horizontal mattress, we were driving it parallel, driving the needle parallel to the defect and not really passing the needle through the defect. Here with the vertical, we did pass the needle across the defect, kind of from further out and then from closer in. Let's just do one more of those. One of the ways that some people describe this is to say you're going far, so far away from the defect here, and coming out far away, so it's far, far, and then as we flip this around, now we're coming near, near. Protect our needle there. And so again, you can see you're really taking big bites, the sutures passing through this healthier tissue quite a bit removed from the defect itself. And as we tension that down, you can see how that really creates big compression deep down in there. 3 throws for chromic. You can even see just in the kind of the way this tissue bunches up, the difference between the horizontal and the vertical. The vertical really brings all of that depth of tissue together, kind of everts the edges a little bit. So horizontal and vertical mattress.
All right. So we had talked about the 2-layer closure of subcutaneous and then the skin above. So this is a subcuticular closure, which again, I'm sure most of you have seen and probably most of you have done yourself. When it comes to starting this, what we typically do if we've got this open defect is that we'll come down to the subcutaneous tissue and do a quick loop through and tie a knot, and then bring the needle out right at the apex, so that when we start doing the subcuticular closure, coming down one side and then the other, and kind of doing this alternating back and forth with the suture kind of lining up directly across from itself. So straight across here, and then straight across here, and then a loop through the subcutaneous tissue, or the subcuticular space through here, and then we would tie the single strand to this loop across there. So that's what they're representing here, is just that kind of side-to-side motion. And there are a lot of ways to tie a knot at the end. There are some folks that don't tie knots, but they'll just leave it pulled through the tissue and then kind of steri-stripped in place. Some folks will do a little knot here above the skin. Lots and lots of different ways to do it. Let's take a quick look here. This is just a kind of a quick and dirty
two-layer closure of subcutaneous space and then a subcuticular. All right, so for our final video here, we're going to do kind of a two-layer closure. We've got a zero bias in here that we're going to use for a deeper layer, and we'll do kind of a running closure there as if we were doing a fascial closure or subcutaneous. And then we've got what I typically use for the skin, a 4-0 monocryl on a cutting needle. So again, we've got 4-0 monocryl instead of the taper. You can see it's got that cutting diagram there. This is a 45 centimeter length, and the needle size represented there. Pop that open. All right, so we'll keep that in reserve. We're going to use our bias in initially here. This isn't a suture that we really use much, but I've got some for practicing suturing. All right, so we're gonna again create this defect with some depth to it, and then we're gonna close. So we're gonna reserve this 4-0 monocryl for doing a kind of subcuticular closure, although the skin here, the chicken skin, is really quite thin, so we're gonna do kind of a modified subcuticular, but just to go through that a little bit. So we're not going to come all the way up to skin edge with our bias in. We're just going to close off this deep space, this kind of potential space. My chicken breasts are getting warm, so they're losing some of their muscular integrity here. So doing a deep bite there, and we'll tie that. Filaments pull through quite nicely. Set that to the side, and again, two-handed knot. So over thumb, create that loop, come through, and then over finger. We're not going to pull this too tight. Over thumb, because if we pull it too tightly, it'll just tear right through. It's a bit of an air knot. So we've got 4 throws there. We're going to cut just our short strand, so we can do this as just kind of a quick little running. So using the forceps to kind of evert that edge a little bit, kind of pull that out of the way so I can do my pass. So you can see that I've almost used the entire needle length just to do my first bite, so I'm really not going to be able to come across probably and do both sides in one bite. So I'll just come out in the middle, reload down here at the tissue, take my second bite through here. If I did want to try to do it in one bite, I'd have to really choke back on the needle. Again, we don't want to grab way out here with this wedged in, because it might, in crushing that, detach the suture. But if I back way off, I might be able to do, so come across there, and then come across there. And we're not doing a locking here, but just this quick little running. Just to close off that deeper tissue. And then tie this one here. So again, because we've been doing this running, we have a loop here and a single strand. So we just kind of treat the loop as a single piece of suture. Over thumb, cinch that down, over finger, over thumb, over finger. So that's 4 throws, 2 complete square knots. We'll cut this kind of short just so it doesn't poke up through the skin. Scissors are losing their sharpness. All right, so now we've got essentially the deeper area of this closed, and we're going to kind of simulate a subcuticular closure here. So we're not going to be going only through
the skin itself, but just kind of treating that as if it was one thing. So we'll hope that the skin kind of stays stuck to that, although it's not. But I'll show you how I kind of approach these in general. So you can see with the 4.0 that is a very tiny needle, and that the suture itself is quite fine. These pickups are actually a little bit big, so I'm going to come up here, get something that's a little bit closer to my adsins. You usually want to match the tissue, not only, match the forceps to the tissue that you're closing, but also to the size of the needle. So with our real large suture, large needle, heavy tissue like fascia, we would use a heavier forceps like the Ferris Smith or the Bonnie's. When it comes to fine work with a maybe 3.0, but certainly with the 4.0, having a smaller needle driver is nice. Having the smaller tipped forceps, this is a kind of an adson, is nicer. So with the subcuticular, I start that off with a bite that's actually below the skin, that's kind of deeper down, and this is just to anchor this suture. So I'm going to pull that through. I don't have my reading glasses on. I'm going to try to. I'm just going to do a one-handed tie here. So again, loop it over these fingers there, trap it, pull it through, over the index finger, pull through, over these two, through, finger, through. 4th row is 2 complete score knots for monochrome. And we'll cut just our short one. So what we have now is we've got, let me try to zoom in here so we can see this a little bit better. We've got our knot down here, kind of in that deeper tissue. And we're a bit away from the actual apex of the skin. So what we're gonna do is we're gonna come through the deeper tissue to pop out right at the apex, right there. And this is where we're really going to start the closure of the skin itself. Sorry, I'm getting my thread wrapped around my tissue here. This is where it pays to have a good assistant. All right, so what we do for the subcuticular is we're going to be passing immediately under the skin edge, and we're going to be traveling parallel to it. So we would come in here right at the apex and then pop out there. And again, because this chicken skin, and especially as this has gotten a little bit warmed up, the skin's separating from the meat underneath just a little bit, but we'll see if we can't kind of simulate this somehow. So if you can see where the suture is here, we want to go directly across from there to start with our next bite. So we would do that, and again, we can kind of grab here, stabilize that skin edge. As we pop the needle out, we'll drive that through just a little bit more. And again, we try not to grab the needle tip itself, because that will really dull it down. So yeah, we're not really capturing skin, but we're getting kind of this very superficial closure. So we'll kind of treat this as skin. So just in here, travel down parallel to the skin edge, pop out right there, staying fairly superficial. And we're making sure to not lock this. My lighting here, of course, not quite as good as we've got in the ORs. And so just back and forth, one side to the next. Come in here, travel down parallel. This side, it seems the skin edges, that skin's a little bit more attached, not a lot, but some. So you can see that I've come out right here, so my next bite would be going in right here. I usually take a couple, 2 or 3 bites and then pull it all the way through. Yeah, so again, with how loose this skin edge here, it's not really trapping it over, but you can see how it's closing this defect very nicely. And with a completely buried suture line, because we buried our knot down in that deeper tissue to anchor it, and now each of the bites that we're taking is actually just right underneath the skin edge. So again, you can see where my suture is here, where I've come out. So I'm going to go in with my next bite directly across from that, travel parallel down, pop out to there, drive that through just a little bit more. All right. And then as we're getting down here towards the end of the defect, you can see where our knot is here from that bias-in that we placed. We would come just right to the end. So we're going to do one more here, probably on each side. Oh, I forgot to use my finer AdSim-like pickup. And one more kind of there. This is just kind of going through the tissue. We're a little bit beyond where we had really created that defect, since our skin edge is being a little bit tricky. All right, so let's say that we had, I'm just going to do a quick little bite there. All right, so our final bite here, coming out right at the apex where our skin edge is cut. And then one more little bite right through this side, again, kind of coming out right at the apex there, trying to not come through skin itself. All right. So now we've got loop and single strand, and again, this, if the skin was really connected to the underlying tissue, it would be bringing that edge nicely together. But we can go ahead and tie this. All right. So subcuticular closure, again, with our skin here not really being connected, doesn't really do justice to that, but you can see here when we're just under the edge of the tissue how it brings those edges together nicely with a buried suture. So. All right, so that's a bit of an odd subcutaneous closure because, as I mentioned in the video, with the skin not really being attached to the underlying tissue, it ended up really being more of just a kind of pseudo subcuticular closure of the meat itself, not the skin. I trust that with what you've seen and done yourselves previously throughout med school, that this just was building upon what you've already seen and probably done. And we'll have the chance to practice this a lot. All right, so let's talk about a figure of 8 suture. We use this as a hemostatic suture. One of the things we'll talk about in the video is that if you have a point of bleeding, that you want to get good compression all around that you can take one bite up here and then kind of travel down, take another bite here, and then tie it like this. So you get this X, or this kind of cruciate sort of structure to the suture that's really going to compress across in really both directions there and perpendicular to that. So that's what this is demonstrating here. So they would have entered here, come down, and popped out here, and then you just bring the suture, the needle across, pop in here, travel down, pop out here, and then tie it across that way. Figure of 8. One of the things that I think is kind of most important with this is that, you know, if you have an area of bleeding, you want your figure of 8 to be surrounding it, so on either side of it. Occasionally I'll see folks who do
If this is an area of bleeding, I'll see them do a figure of eight that's kind of like here and here. It's like, well, you kind of missed the spot. So identifying where the bleeding is actually coming from is important to be able to plan the placement of your suture. Occasionally, you'll do a figure of eight and not really get the tissue compression that you're looking for. So if this was our area of bleeding, and let's say we did a figure of eight like this, and it's still bleeding, if I was going to do another suture there, another figure of eight, I would do it perpendicular to how I had done the first. So there still would be this first one that's kind of crossed over like that, but if that didn't do the trick, then like I said, just go perpendicular to that with your next one. Don't simply repeat the exact same suture that you had just done that didn't do the trick. So let's take a look at this figure of eight. All right, let's talk about figure of eight sutures. These are sutures that we place for focal hemostasis. We're going to switch it up a little bit with our suture. We've got a 1 chromic on a CTX needle. I tend to use a CTX for closing the fascia and for closing the uterus, not with chromic. But as we pull this out, we can compare the size of this needle, the CTX, to, this was our CT1 that we just used for our running interlocking suture. So you can see the difference in size there between CT1 in the needle driver and the CTX that I'm holding. So the CTX, just a little bit of a hardier needle, is quite a bit longer, has a bigger radius, and so hence diameter to the full circle that it makes. What we've got here, I created a small defect here, and we're going to say that that's our area of bleeding. Let's just get a little bit more zoomed in on that. So, one area of bleeding, we don't really need to do a running suture because we don't have a length of defect that we're closing. To do an interrupted, we could try to do a single interrupted across that, but if there are blood vessels that are coming in making this little area bleed, doing a single interrupted and kind of tightening across this line, or really any single line of pressure, might not do the job. So if we really wanted to make sure this is hemostatic, what we do is come up above it, and this is a little bit of a big needle for this, but we come up above that area with our first pass. So you can see we've got there above, and then our second pass we come just below it, so just keeping that area of bleeding right in the middle of our suture. And then as we tighten this down, what we see we've got is a nice area of compression, because now as we tie this, we've got kind of that X or 8, so figure of 8. But we've got compression really surrounding that area of bleeding. So no matter which direction those vessels are coming in from, or if they're coming up from a little bit deeper, we've got good compression there. So again, for me, I've got the needle here on the left in my needle driver. So I set that to the side, keep that covered up and protected. I've got my free end here in the right. I'm going to pull that through just a little bit more. And so again, what I do is I don't cross strands in this scenario, but just come over thumb, make that loop, swing it through. And figure of 8 sutures are one area where I do tend to do surgeon's knots, because oftentimes you've got a pretty big area here that you're trying to compress, and we really want that first throw to remain tight to keep that tissue under tension while we do our second throw, completing our first square knot. So a surgeon's knot would look like we make our loop, we go through just like we normally would, but then instead of pulling this tight, we just go and loop again. So again, over the thumb, pull that loop through. So now we've got 2 wraps of the suture together. You can see it's a little bigger, a little bit harder to pull down, but as we pull that, it really compresses that, and now we can take tension off of it, and it stays quite tight. So that's the benefit of the surgeon's knot, is that when you cinch it down just with a single throw, so to speak, although we have 2 wraps, it keeps it nice and tight. So again, that first time was over thumb, so second time loop over index finger, pull that through, and there you go. And then again over thumb, and we'll just do a single throw here, and then over finger. So that's 4 throws, 2 complete square knots, which for chromic is 1 more than you need. And there you go. So you can see that we've got just kind of a bunching up of that tissue, and that's our figure of 8. We'll do 1 more of those here just to kind of highlight it. So let's make another little defect kind of here. So let's say we've got a little bit of a bigger area. And again, not quite enough length here to do a running. Maybe 1 or 2 interrupteds, but like we saw over here, the tissue between the loop of interrupted, there's not a lot of tension here in between. So for a figure of 8, and the one we did down here, we went kind of horizontal, I guess, to the defect itself. So this time let's go vertical. Let's start here. And then for our second throw, some people like to kind of grab onto these 2 and kind of pull them up. That's perfectly fine if you like that. And then for our second, we'll come here, like that, and pull that through. And again, we're creating this kind of this X shape to close over that. Just pull that through so our tail's not quite so long. And then again, I'm going to do over the thumb once, twice for our surgeon's knot, and just a slow, steady cinch that down, and then over finger, come back over thumb. So that's 3 throws, 1.5 square knots. That's appropriate for chromic. Cut that. And again, you can see how it just really bunches up all of that tissue. So that's our figure of 8.
All right, so that brings us to the end of this video. I will be posting the videos of the suturing individually on the channel. Let's see if we can expand this up here a little bit. Hello. So you'll be able to either watch those individually or fast forward kind of through the PowerPoint slides. I hope that this has been helpful. Obviously, I'll have a chance to talk about this stuff in person during the simulation session, and then especially throughout the first several weeks and months up on labor and delivery as you're doing some procedures there. And we'll be practicing this in the hospital, and then also giving a strong recommendation to be practicing at home as well. So, thank you.